So good evening, all the students present here. So today topic is endocrine disorder, and the faculty that we have here is Fathy Elshazly sir. So you may take over. Thank you.
Thank you so much. Um, Good evening, everyone, wherever you are. I know it might be too late now. I'm very sorry for that, but it's still in the afternoon here in England. So, our topic today will be about endocrinology. Endocrinology usually it's comes in every exam, but usually when they bring endocrinology cases, they either bring them on the CBS, either in the form of CBS case-based scenarios to identify where is the problem from the chemistry, or if they bring it in the CCS, they usually bring it either a short case or a vignette of a long case. A vignette means that it's a portion of the long question, either the admission diagnosis or sequelae of prolonged stay in ICU or the therapy which is being given while they are in or on the ICU. So actually, I thought since I was asked to prepare this lecture, what is the best way to deliver this session to make it useful and at the same time take as much information out of it, and most important, not to make it boring, because endocrinology is a very, very boring subject. Uh, so instead of doing long case, like we did in the other previous sessions, we are going to just do a short cases so that we can see a lot of examples, and you can gather as much information as we can. And as I'm always mentioning, those kind of sessions without your participation are useless. So please just try to participate as much as you can to get the benefit out of it, and not to get bored easily, because you might get bored easily out of this session. And I hope that the way I designed the session wouldn't make that boring for you. So the first case, as always, I'm going to ask a volunteer to just you can hear my voice and you can see my screen, right? Any answer, please? Can you hear my
Yes,
voice?
we are hearing you very well, and
And you can see the screen. Okay. Okay,
Yeah.
thank you. Okay. Because actually I'm struggling. I don't know why it's happening now. Okay. Okay. So I cannot see the participants for some reason, but anyone can read the question, please, for us. Any volunteer?
Okay, let me
Okay.
read.
Okay, thank you, Dr.
Okay.
John.
Yeah. 54-year-old man who has been admitted to intensive care with a community-acquired pneumonia and septic shock. He has a history of insulin-dependent diabetes mellitus and depression. He is currently ventilated and receiving vasopressors and renal replacement therapy. After 10 hours of aggressive hemofiltration, he continues to have a refractory metabolic acidosis. What are the main differential diagnoses of persistent acidosis, and what further investigations would you request? We have, I think, the lab results. Should I go ahead and read out?
No, it's okay. Just read
Okay.
them. Just read them without letting us know. But
Okay.
I because it's from an English book, so I brought the units in milligram per deciliter, and regarding the creatinine and urea, and then regarding the BO2 and BCO2 from kilopascal to millimeter mercury, so that if you are not used to those kind of units. So when you are ready, just let me know, please, Dr. John.
Okay.
Okay. Any differential diagnosis in your mind at the moment? Usually in the exam, have 5 minutes to go through the vignette, but we'll try to shorten it a little bit now. I'm sorry for that, but I know it's a long case, but any differential diagnosis in your mind?
Okay, the main differential diagnosis I'll quickly think of right now is one, there is still uremia despite the ongoing renal replacement therapy. And although I didn't see the ketones, but I think it's also possible that he has some DKA, diabetic ketoacidosis. It's a possibility, even though there's no result for ketones here.
Great. Great. Okay, what else?
So even chloride is not available. I would like
Sorry?
to chloride values are not available, and
Very good.
then
Yes,
because
exactly.
it's insulin dependent diabetes mellitus, I would like to calculate the anion gap, and albumin might be useful. Oh, we've got the albumin here, which is low, which will help in calculating the high anion gap acidosis. And because I'm not sure if the patient has been fed as well, so that could be possibilities that the patient might have some kind of starvation ketoacidosis as well. Obviously, urine and the serum ketones would definitely help with that.
Lactates are also high, sir. Lactic acidosis.
Yes, so it might be hyperfusion, right?
Acidosis may be septic due to septic shock, and maybe drug overdose as patient is on treatment of depression.
Okay, that's good. That's great. That's what we need in the exam, that we always need differential diagnosis. Even if you got the right diagnosis from the first time, they usually appreciate that you always have a broad mind, that you always look for differential diagnosis, other possibilities. Okay. So, and they are going to ask you always, what else, even if you got the right diagnosis from the first one, they are going to always to ask you what else. So don't be offended or pressurized by that. It's normal. It's part of the exam because they want you to give the full mark. So they are going to keep asking you what else. Okay. So this very good differential diagnosis actually from all of you. So as you all mentioned, hyperfusion would be the first thing we are going to look for, especially in the presence of high lactate. We would like to check the cardiac output via the minimal invasive methods like PICO or via the echo or whatever the cardiac output you have where you can get. Sometimes I know it's out of date now, but some people still depends on the venous saturation, although it is not recommended anymore. But you have to check for the perfusion and of course clinically whether the patient is hyperfused or not. You might be an ongoing acute kidney injury that you might and the filtration is not correcting it, and so you have to change your filtration settings in order to tackle that. Can be diabetic ketoacidosis as mentioned by John, can be hyperchloremic acidosis as well, which was mentioned by you, and that's why you need the chloride level, can be unmeasured anions, and can be due to drug toxicity as well. And that's why it's always usually in any case, whether chemistry or anything which is discussing biochemistry of the body, usually the answer in the anion gap, osmolar gap, and sodium homeostasis. Most of the cases are about those three things actually regarding when we are talking about any endocrinological or chemical disturbance or derangements on critical ill patients. So his serum ketones are 7.5. How would you manage this? John, okay, we'll continue with you, okay?
Yeah. Okay. If his serum ketones is 7.5, that means one of the causes of this metabolic acidosis is coexistent DKA. Well, in this case, I would like to review the insulin administration in this, and with a blood sugar of 16 millimoles, I would like to optimize the insulin, starting on insulin infusion, if he's not been on it already, intravenous insulin, then using a sliding scale to determine to control the level of the amount of insulin to give, while continue to measure his blood sugar hourly, blood glucose hourly, and then they also monitor the urine ketones and then the ABG.
Great. Anyone else would like to add anything?
Fluid resuscitation and insulin infusion.
Okay, that's good. Anyone else? Okay. You are all right, but
okay,
there's a difference between being right and being given correct the answer they are looking for. You are all right, but you have looking for the answer or the term they are looking for here. Of course, this patient has been for obviously many hours or maybe many days on the ICU. Most probably he will be on mechanical, he's on a filter, and if he's on filter, he's on CRRT, continuous renal replacement therapy. So if he's in continuous renal replacement therapy, most probably as well he's intubated, ventilated, and he's on vasopressors might be receiving steroids, corticosteroids in the form of hydrocortisone, stress dose, and he might be, and of course, most probably he will be in insulin infusion. Okay, like any other diabetic patient in ICU. The terms they are using here in England or in Europe, there is two terms you have to know regarding the insulin infusion, because the terms can differ from country to another. So, for example, if I'm going to say sliding scale in the Middle East or India, maybe it's going to be different from what's meant by sliding scale here. And every hospital or every country or every maybe trust has its own kind of sliding scales protocols. Sliding scale means that I want a target for this patient that, for example, 10, which is equivalent to 180 in milligram per deciliter. And I'm asking the nurse to follow the sliding scale insulin infusion protocol in our hospital. And they're usually protocolized either A, B, and C. A is the mildest one. That means the maximum, for example, the maximum unit per hour would be 5 or 6. In B, no, you can go up with the sliding scale up to 8 if needed. C, you can go the sliding scale further. So John asked us for sliding scale for the insulin infusion in a patient with DKA. They are not looking for this kind of answer. They are looking for fixed rate intravenous insulin infusion. So here we are dealing with, you should have fixed rate. Fixed rate means 0.1 unit per kg per hour or more. Sometimes we have to reduce it a little bit to 0.05 if the patient becomes very hypoglycemic and we cannot control his blood sugars with the glucose 10% or 20%, but it's called fixed rate insulin infusion, which is 0.1 unit, which is anti-ketotic dose, called anti-ketotic dose. And of course, I mentioned here normalized glucose level. We are not looking for normalization of glucose level. We are looking for a target glucose level of 14 millimole or 250 milligram per deciliter. So if I can find whether I have increased the insulin infusion up to the anti-ketotic dose, which is 0.1, then immediately I should start the glucose infusion and keep the anti-ketotic dose of the insulin. I shouldn't go to sliding scale. At this point, we shouldn't go to sliding scale. I should go to what's called DKA protocol. And any hospital in England or in Europe have a DKA protocol and have a different sliding scale protocol. And if there is if this kind of patient, this usually are complicated patients. So yes, as mentioned by Dr. Muhammad, we have to give them normal saline and balanced crystalloids. But at this point, the physician or the clinician should step in. We should not follow the protocols exactly as they are, because this patient is an acute kidney injury. Most probably he's anuric. or oliguric at least, and he's on a filter. That's why he has got multiple organ failure, has got respiratory failure, has got renal, acute kidney injury or renal failure, and he might have some sort of cardiac depression as well. So the fluid resuscitation should be very, very closely monitored and under strict medical supervision. We cannot let the nurses follow the strict DKA protocol in this kind of cases. So, and how we are going to monitor this kind of response, either, of course, either by cardiac output monitoring or by echo or whatever clinical examination of the patient, and look for any signs of hypervolemia. And the most important issue here will always, as I mentioned earlier, it would be the sodium balance or sodium homeostasis. You don't want the sodium to go down so fast or go up so fast. If it go down so fast, it will cause brain edema, or goes up so fast, it might cause what's central pontine myelinolysis. So it's about the sodium homeostasis, and of course, we don't forget about the potassium, which is already, there is a protocol for it in any hospital, and don't forget about hypophosphatemia. So all of you were right, but we have to structure our answer in the way they like to hear it. Okay, so fixed rate insulin infusion, proper or judicious fluid resuscitation, give glucose once the glucose level targets are reached, which in here 14 or 250, not 10 in that other kind of critical ill patients. Monitor the electrolyte imbalance closely every 2 hours at least, and monitor for other like sodium, potassium, and phosphate. What are the treatment targets should you aim for? Who would like to answer this question?
Treatment targets would be clearance of ketone bodies from the blood, and also achieving
By how much? How? What's your target? Could you tell me a number, please?
less than 2.
Okay. What else?
And also achieving a bicarb level of more than 15.
Okay.
Closure of an ion gap, sir.
Okay. Well, great. Yeah.
There are hourly targets usually. Every hour, I think we need to monitor, do a blood gas and serum ketones. I think every hour ketones should drop by 0.5 millimoles per liter, and other glucose, and need to make sure potassium is normal as well, and the bicarbonate is also improving by, I'm not sure what the value is, but I think hourly we need to monitor and then make sure it comes down at a gradual rate rather than very fast, to prevent further cerebral edema from happening.
Great, especially in young patients. So that's great. Actually, that's good. That's the right answer. Targets. This is according to the British. Of course, usually the DKA guidelines are the same for all the societies, but this is taken from the British. Blood glucose reducing by 3 millimoles per hour, a fall in blood ketone concentration by 0.5 millimole per hour per liter per hour, as you mentioned, increasing venous bicarbonate by 3 millimoles per liter per hour, maintain potassium between 4 and 5.5. Those are the targets that we are looking for in those kind of patients. And again, I'm not trying to make it a theoretical kind of lecture. I'm not going to teach you how to treat DKA. You can do it better than me, but it's about the kind of questions. Unfortunately, the EDIC examiners or the EDIC exam in general, they are trying to deviate away in the OSCE exam from asking you some theoretical questions. But sometimes they have to ask you some theoretical questions, example, in those kind of patients, to be sure that you know the pathophysiology of the disease itself, and you know your targets. So maybe you can find it's some sort of theoretical question, but actually it's not theoretical, it's a clinical question. Okay, and just like when I the last session when I was asked, and I was asked this question in my exam as well: how come citrate, for example, correct the acidosis, or why the patient with hepatic failure they might easily develop citrate toxicity when they are on citrate through the continuous renal replacement therapy. So this kind of questions, you might find it in the exam. Maybe it's theoretical, maybe you can find it, but it's not theoretical, it's clinical, because it's integrated, it's integrated in our daily clinical practice, actually. So what would you do if your targets were not being met?
Be a bit more aggressive. I think can go up on the insulin, fixed rate insulin infusion from not 0.1 mils per kilo to maybe a little bit higher up to make sure it comes down.
Great, that was the right question. Increase fixed rate insulin infusion and keep it fixed. Keep it fixed, okay? And if you need, you can increase the glucose administration dose as well. How would you manage the CRRT settings? As we mentioned, this patient, we cannot give labral fluid administration. He has got multiple organ failure and he's on dialysis or hemofiltration. How would we manage the CRRT settings here?
We will like to start with CVV-HDF mode of CRRT and access preferably in the right internal jugular vein. And then the dose of CRRT dose is usually recommended by KDIGO guidelines, 25 to 30 ml per kg per hour. The KDIGO has recommended 20 to 25 ml per kg per hour, but in order to counter for the 10% downtimes in CRRT, we keep it around 30 ml per kg per hour. So if this is a 60 kg man, it will be somewhere around 1800 mils. And then we will divide this into half into the dialysate and the replacement solutions. So 900 dialysate, 900 replacement, 2/3 and 1/3 pre and the post replacement solution. So 600 pre and 300 post replacement solution. And I would like to use bicarb based replacement solutions because the patient is having metabolic acidosis. And fluid removal, initially I would like to keep low nil because patient is hemodynamically unstable, and maybe later on, as per my dynamic prescription, I will increase the fluid removal. And I will
increase the fluid removal?
regional citrate anticoagulation.
Sorry, what about the fluid removal? Say it again.
Sir, because this is patient is in septic shock also, so initially I will start with 0, but later on maybe I can increase as per the monitoring. Later on, I can go up to 1.5 to 2 mils per kg per hour maximum dose. And
okay, Priyanka, right?
Yeah,
Priyanka?
sir.
Priyanka, you never disappoint me, Priyanka. You're always great answer as usual. So, as mentioned by Priyanka, but I will just initially we are taking care about the initially. The patient is already in CRRT settings. So, Priyanka, why you are going to use CVV-DHF instead of CVVH?
Because I want solute clearance also. The patient is having AKI, so I want hemofiltration also and dialysis. I want both convection and diffusion functions of the CRRT.
That's very good answer, actually. Very good answer. Although it is not mandatory, but it's a very good answer. You have, if they ask you this kind of question, they are allowed to ask you some questions outside the syllabus or outside the pre-written questions, but to know how you are thinking, because at the end of the exam, even if you think that you didn't perform well, both examiners, they sit together and decide whether they should let this student or candidate pass or not. So it's about usually how to impress the examiners. Even if you didn't say everything in the model answer which they have, sometimes they can let you pass if they really impress them. And I can see that I'm really impressed by your answer. It's very good and very detailed answer, actually. But I just object about the fluid removal, but you give me good justification. But initially, of course, we'll have to reduce or stop the fluid removal, choose the fluid replacement according to the serum potassium levels. The dose of CRT replacement could increase up to 30-35, or we can shift the patient to CVV-DHF, as you said, or even SLED if possible. And of course, according to hospital protocols and MDT decisions, MDT means multidisciplinary team decision. That means, for example, if there is someone who's responsible about continuous renal replacement therapy, whether he's, for example, nephrologist or intensive care nephrologist or someone who's we can ask them to intervene as well. And of course, in addition, always mention clinical and cardiac output monitoring to detect any signs of hypervolemia or pulmonary edema. Okay. So, would you use a bicarbonate infusion for this patient? Why or why not?
Usually, bicarbonate infusion is not recommended for diabetic ketoacidosis because it can cause cerebral edema if given. But there are instances, especially in in cases where there's refractory metabolic acidosis in the form of pH less than 7 after adequate treatment, and we know the cause of acidosis is still DKA. We can try some bicarbonate infusion, but in this patient, because the patient is already on a CRRT, I wouldn't want to give bicarbonate infusion, rather give bicarb through the replacement fluid.
Okay, great answer actually. So who's this? Who's the one answered it?
It's Karthik.
Karthik, great answer, Karthik. So, yeah, great answer. So as you mentioned by Karthik, it's not preferable. It's usually contraindicated or not preferable to give bicarb should be avoided because it might increase the partial pressure of carbon dioxide, and carbon dioxide, as all you know, can penetrate into the CSF and can cause CSF acidosis, and in addition to intracellular acidosis as well. And the use of bicarbonate in DKA might delay the fall in blood lactate and pyruvate ratio and the ketones when compared to intravenous sodium chloride. And of course, there are reports that bicarbonate can contribute to cerebral edema in children and young adults. But as mentioned by Karthik as well, in cases of life-threatening emergencies or peri-arrest status, we are allowed to use bicarb. For example, severe hemodynamic compromise, severe shock, pH less than 6.9, severe hyperkalemia with cardiac instability or impaired myocardial contractility due to acidosis. At this point, bicarb can be life-saving. But of course, you shouldn't be very generous in giving the bicarb. We should always be cautious in giving it. So, what are the main differences in fluid and insulin regimes between hyperglycemic, hyperosmolar state, and the DKA, and why?
There is not much of insulin deficiency in HHS compared to DKA, and HHS happens over a longer period than DKA. So we should be really HHS patients are really more dehydrated compared to DKA. So they definitely need more fluids, but it has to be done in a very gradual way rather than a sudden way, because it can worsen the cerebral edema that the patient has got. And insulin regimes, I don't think there's much of a difference in insulin regimes, but correction should be much more gradual compared to DKA.
Anyone would like to add anything else?
Insulin regime in DK is 0.1 unit per kg per hour, and in HSS is 0.05 unit per kg per hour.
Okay.
Initially.
Not 0.5, not 0.0, not 0.05, right? Or 0.5. Sorry, can you say the dose again?
0.05 unit. 0.05 units per kg per hour.
Okay. Yes, that's good. Okay, all the answers actually are right answers. There is no clear right or wrong here. Usually in HS, there is much more severe dehydration actually, and it's usually in older patient and usually non-insulin, not type 1 patients. But usually the fluid deficit more or less the same. But those kind of patients, as you mentioned, are more sicker. The hyperglycemic osmolar status are more sicker and usually are more prone to brain edema more than the other DKA patients, especially the chronic diabetic type 1 patients. Usually they are, when you see them in their DKA, you feel that they are actually normal, actually. But actually, when you do a blood gas, you find that they have frank DKA, and obviously they can feel themselves better than anyone else. There is a kind of information that actually the first time to see it here, but that slow correction of hyponatremia as well. I know that correction of hyponatremia might cause some sort of rapid correction of hyponatremia, might cause central pontine myelinolysis, and rapid correction of hypernatremia might cause cerebral edema. That's what information what I usually know and I usually practice. But while I was preparing for this lecture, actually I found some sort of information which is not very common, that those kind of patients, hyperglycemic, hyperosmolar state patients, have increased risk of developing central pontine myelinolysis as well if their sodium levels are being corrected too fast. So I didn't know this actually before preparing for this lecture, and I'm not very sure if it is correct
Corrected
information.
sodium would be low. Corrected
Sorry?
sodium would be low. I think serum sodium
Yes.
would be high, but corrected sodium would be low.
I know, but that's what we know. But actually, I have to check it again. Actually, that whether those patients, hyperosmolar state patients, are more risk of hyperglycemic, hyperosmolar patients are more risk of central pontine myelinolysis if we try to correct their sodium levels too fast or not. Whether in either way, but I have to check for it. But I found it while I'm preparing for this lecture. I wanted to share with you to see your point of view about it as well, because we're all learning from each other actually. So what kind of complications are both HHS and DKA patients are at high risk of? What kind of complications that you are afraid from treating those kind of patients?
Hypokalemia due to the insulin treatment. Risk of hypoglycemia is also there. So close monitoring of blood sugar levels.
So this is the therapy-induced complications. But what are the complications of the disease itself, of those patients, if you don't treat them properly? What they might develop?
Cerebral edema and hypophosphatemia. Several electrolyte imbalances can occur.
Okay.
Thrombosis also can occur.
Diabetic coma can occur if the treatment is not.
But this is coma. They are in coma already. Those patients usually they come in coma. So this already have got coma. But what else can happen to them? We mentioned the cerebral pontine myelinolysis. We mentioned brain edema. What else if they're not being treated?
Due to
Prone to
hyperosmolar states
thrombosis.
and hyperviscosity, they can have
Exactly, hyperviscosity. So always in your answer, which we mentioned earlier, action plan always thromboembolic events, including deep thrombosis. So they always have to, which is very common actually, and that's why they always should have prophylaxis, anticoagulation. Even some people, even if they aren't citrate through the CRRT, through the continuous renal replacement therapy, they should receive thromboembolic prophylaxis, whether low molecular weight heparin or unfractionated heparin, pulmonary embolism, cerebrovascular accidents, myocardial infarction. So all of those, the severe events are usually vascular complications. This is usually due to under treatment, but obviously this happens usually either the patients in our unit, once they have got access to the intensive care, they usually die from the treatment itself, from the heterogenic complications, especially brain edema. But those patients who don't have an access to intensive care, usually they die because of those cases, because of either thromboembolic events. So we have finished now the DKA. So because I intended to make it short cases, so we don't spend too much time on it. So this is a new case. Who's the volunteer this time? Anyone other than John? I can see a lot of participants.
Sir, I would like to.
Priyanka, okay. Priyanka, sure.
68 years woman brought to emergency department by her ambulance, found unresponsive at home, lives alone. Her past medical history is unknown. She is heavy smoker. Her neighbor reported that she has been increasingly sleepy, cold, and sluggish over the past week. On arrival, airways patent, respiratory rate is 6 breaths per minute, saturation 91% on room air, blood pressure 88/50, heart rate 42, temperature 31 degrees Celsius, GCS 7, E2V1 M4, pupils equal and reactive, hypothermia, puffy face, dry skin, slow reflexes, mild pretibial edema, capillary glucose 75 milligram per deciliter, mild cardiomegaly, and small left pleural effusion. So
now you have got the ECG, at ECG trace, and you have got the bloods. Could you read them and then to let us know what are you going to do with her, please?
So ECG is showing bradycardia. Sir.
What kind of bradycardia is it?
It looks like a junctional rhythm only.
Okay.
Or no, it's a ventricular rhythm.
Okay.
And with QT interval prolongation, and heart rate is
Heart rate is already mentioned up. So heart rate is already mentioned. Okay. So what I just could you read the lab results? Could you read them between you don't have to read them loudly, but okay. I wrote the units of creatinine and urea in milligram per deciliter units, and the PO2 and BCO2 as well in this example. I haven't done this in all the next next cases, but that's what you'll find in the exam, that you'll find they're going to give you both units, because you know that every country has its own unit. So, ready?
So this is hyponatremia, hyperkalemia, hyperuremia, and creatinine is also high. CO2 is on a higher side with little bit of hypoxemia. Patient is having GCS is also low.
Okay.
And patient
What's
is
your differential diagnosis then?
It could be a metabolic cause. It could be electrolyte hyponatremia leading to decreased sense of GCS. It could be hypothermia. It could be some intoxication, some unknown intoxication in this patient, or it could be any cerebrovascular event. I mean, I can keep a differential and.
Myxedema coma, myxedema coma, Wilsonian crisis.
Hypothyroidism with
Let's just let one candidate answer for now. So you can raise your hands if you want to answer about anything else, but let Priyanka now to make it more more like a simulation for them. So Priyanka, now your differential diagnosis is hyponatremia, and what else? What kind of hyponatremia is it?
So can we go back?
Okay. Sorry.
Serum osmolality is low with hyponatremia, so it is hypotonic hyponatremia.
Hypotonic hyponatremia. Okay. Anything else? Any other differential diagnosis?
It's hypothyroidism.
Please let her please. Sorry, please let her answer, please. Give her the chance. Okay. What are the other differential diagnoses? What else?
So it could be because of hypothyroidism. This hyponatremia is because of hypothyroidism also.
Okay. What do we name this case then? If it's hypothyroidism, what do you name the condition?
I'm not able to understand, sir.
What's the name of the syndrome? What's the name of the
myxedema coma?
Okay, myxedema coma. What else other than myxedema coma?
Sir, because this patient is having cardiomegaly and pleural, so it could be myxedema coma only, hypothermia, puffy face, slow reflexes, mixed pretracheal edema. So all this is pointing towards myxedema coma in this patient.
Yes, exactly. So what else?
Cushing syndrome is possible. The cortisol level is quite
Cushing.
high.
Yes. What else? What else?
KITC, critical illness, steroid insufficiency, another cause.
Sorry?
Adrenal insufficiency.
It is called
Adrenal
critical illness.
insufficiency. Anything else? Anything else?
Okay, crisis.
Okay. So as you mentioned, all can be myxema coma, can do acute exacerbation of COPD, can be sepsis or septic shock, can be adrenal crisis, can be hypothermia of any other cause, environmental, can be drug overdose like opiates or sedative, can be stroke or intracranial event. So all of these can be simple causes, but we have to mention them all. Okay. So actually, I tried to make it a little bit more difficult. Suppose in the scenario there was macroglossia, big tongue, but I removed it. From this scenario, sometimes from clinical scenario, you don't know if this patient looks hypovolemic or hypervolemic. She's edematous. She looks edematous, but is she hypervolemic or not, or is she hypovolemic or not? And it's always about the sodium in these patients. It's always about the sodium. But here they give you another hint. They give you chest X-ray with there is pleural effusion. They give you an ECG where there is bradycardia. The patient looks puffy, hypothermic. Of course, you don't expect that this patient that have thyroid history and they're not going to, and she has not taken her medications for it, so they're not going to make it that easy for you. Usually they're going to bring a patient, we don't have a lot of information about them, okay? To make it a little bit to see how, and it's not important to mention exactly the right diagnosis. The most important issue is to structure a reasonable kind of differential diagnosis. Okay, that's the most important thing here, to give a reasonable differential diagnosis. So what's your action plan? Who wants to answer this question?
Me, sir.
Okay, Priyanka. So please, if Priyanka is going to start, please don't interrupt her until we ask you to intervene, so that we can, all of us, because when I ask for volunteer, usually one raise their hand, but whenever someone struggles to find the right answer, everyone wants to speak at the same time. So there will be no kind of useful interaction here. So if she cannot answer, I'm going to ask you to step forward to answer. Okay. So Priyanka, what's your action plan?
So I will follow the hospital policy and I will start resuscitating the patient. I will first manage the airway because the GCS is low. I would like to intubate this patient straight away, and followed by that, I will ensure adequate oxygenation in the patient and give fluids, preferably warm fluids, and I will try active and passive warming in this patient. I will put bear hugger and warm crystalloids, give warm fluids, try to warm the patient and bring the temperature closer to 37 degrees Celsius. And then in circulation, I would like to resuscitate this patient, give fluids, fluid bolus, 200 mils fluid bolus. And then I would like to give specific treatment, that is thyroxine in this patient. And so we can start with 300 mics thyroxine after putting Ryle's tube in this patient. And I would also like to give corticosteroids, injection hydrocortisone, 100 milligram 3 times a day. And
okay, great, Priyanka. And I liked, Priyanka, I like the way you entered me. I will follow the hospital policy. That's kind of answer that they like. Actually, I'll follow the hospital policy. That you are giving a very good impression about yourself. Okay, you are presenting yourself in the right way to them, so that you are a very safe doctor. I'm going to follow the hospital policy, A, B, C, D, E, and then we'll go step by step systematically. So that's kind of answer they are looking for. That you are a safe physician. They don't want geniuses there. They don't want genius people there. They have a lot of genius people. They don't want you smart or brilliant people. They just want safe doctors, safe physician. So always your priority is to prove to them that you are a safe physician. They are not looking for knowledgeable, smart, or genius doctors. They are just looking for safe doctors. And that should be your message to them and how you present yourself to them. So, as mentioned by Priyanka, ABCDE assessment. Then, of course, Priyanka, we haven't reached the diagnosis yet. We have just differential diagnosis, but of course, we are going to do CT brain. Once the patient is being stabilized, You intubated her and she's hemodynamically stable. She can be safe to be transferred to the CT brain, doing septic screen, doing thyroid function test, cortisol level, cardiac enzyme, CK, LDH, and toxicological screen. And then the next vignette, I'm going to show you now the bloods, her bloods. Of course, you mentioned that you are going to insert Ryle's tube and give the thyroid for her, which is not wrong, but don't mention the word Ryle's. The word Ryle's in our countries means any nasogastric, but there is difference here in England, for example, or between Ryle's and nasogastric tube. Ryle's is the tube which we are inserting for drainage. That's how they define Ryle's. NG tube is different. They call it NG feeding tube. They differ in their structure. They differ in their diameter. The NG feeding tube are much smaller diameter. The Ryle's are much bigger diameter. The NGT tube has usually radio opaque, and usually have got a wire inside it. The Ryle's usually doesn't have a wire. Usually there is a line, radio opaque line, in order to allow you to follow it on the X-ray. So just be mindful of I don't think that the EDIC will care so much about it, but maybe if there is an English examiner, they might, especially if your center will be in London or something like this. So they might comment on that, or they might not, they might take it seriously. But just be aware of the difference between Ryle's tube and NG feeding tube. Okay, these are the blood, his bloods or her bloods. So you mentioned your action plan already. You are going to give corticosteroids and you are going to give thyroid levothyroxine through the NG tube. But usually in those kind of cases, they want you to mention you can give NG tube, but you want you to mention the IV as well. Okay. They mentioned to give you levothyroxine IV, because usually those kind of patients have malabsorption and they are not going to absorb it properly, and you need fast action levothyroxine or rapid action of levothyroxine, and convert to oral or NG once stable. Or you might think as well about liothyronine, which is T3, but of course there is risk of arrhythmias, myocardial ischemia. Usually I have never seen liothyronine being given actually. And I have been practicing medicine for ICU for a long time, but I have never seen liothyronine. I have only seen levothyroxine, but but you might mention this in your answer as well. And of course, steroids, because there is usually adrenal insufficiency can be present at the same time in myxedema coma or in even thyrotoxic crisis or thyroid storm. So always give hydrocortisone. So it was a great answer from your part, Priyanka, as usual. Okay. So now I need another volunteer. What are the key ICU management goals here? Any volunteer?
So can I answer?
Yes, Karthik, please. Yeah.
Okay. So key ICU management, as it was mentioned earlier, I would make sure airway breathing circulation is taken care of. And in terms of temperature management, I would very gradually raise the temperature up, because I don't want raising the temperature really fast can cause vasodilatation, further drop in blood pressure, which I would try to avoid. And then obviously hydrating the patient to get the CK levels down. I would like to monitor the renal parameters as well, because the CK was around 1,200. And more urine output. And then I like to do an echocardiogram as well, because obviously the patient has got junctional rhythm with QT prolongation, to see if there is and low voltage complexes as well. I would definitely want to see if there is a pericardial effusion, which is the cause of this problem as well. I would basically go through each and every part of each and every system to make sure that something is correctable, because the prognosis is quite bad. The mortality rate is close to 50% with hypothyroidism. So I'd be really keen on correcting each and every systems.
Great. Okay. So as you mentioned, ABCD, ventilator support, hemodynamic support, thermoregulation by passive rewarming or Berhacker, as mentioned by Priyanka, electrolyte correction, hyponatremia, hypoglycemia, infection control. Usually these are most of them myxedema comas. Usually there is a a trigger for them, and usually those cases most of the time, or even I think, and on all the myxema coma is very rare. But if you all the myxema comas I have seen in my life, and they are not a lot, they are usually triggered by sepsis. So usually they are secondary with sepsis, monitor cardiac rhythm and QT interval, as mentioned by Thanik, and neuro for GCS pupils, EEG if suspicious of status or encephalopathy, and CT brain, of course. So this is another page. This is another. Before we go to the next patient, would you give sodium? Her sodium was 117. Would you give sodium to their hypertonic sodium for her or not? Would you correct this sodium or not?
Usually correcting the thyroxine levels get the sodium up really fast. So I'd be really careful in correcting, because it's probably a chronic hyponatremia. So I wouldn't correct it more than 8 milliequivalents over a span of 24 hours, because it usually corrects quite fast, I've seen, with hypothyroidism management.
That's a very good answer, actually. So there is no right or wrong answer. So some clinicians, if they see that this patient is, as mentioned by Priyanka in the first differential diagnosis, that this low GCS is due to hyponatremia, they would give initially hypertonic saline, 1.8 or 3%, and it's justifiable. But usually you have to be very careful, especially if those patients have got myxedema coma, that their sodium might improve very rapidly, especially in the presence of sepsis or some sort of distributive or hypovolemic shock, especially if it is hypovolemic hyponatremia. Then giving crystalloids alone, isotonic crystalloids like normal saline or Hartmann's or Ringer lactate, in addition to the steroids and the thyroid hormone, usually are enough to improve the sodium above 120, which is your target. Actually, I know that some books writing the targets are 125, but you don't have to treat hyponatremia actively with hypertonic saline as long as the sodium is above 120. Okay, if below 120, you might consider it, you might think about it, but if at above 120, you don't have to give hypertonic saline. So it's a very good answer, actually, because actually you might find it a lot, and you might find a lot of conflict about this in your daily clinical practice. I remember a patient I had seen more than 10 years ago. I diagnosed her as a myxedema coma in the A&E or ER, and obviously the internal medicine consultants, or even not one consultant, a lot of consultants, actually, all the internal medicine in their multidisciplinary team or morning ward round wanted to give her hypertonic saline, actually. But I insisted not to give her, because I already admitted her to my intensive care. I insisted not to give her hypertonic saline, and fortunately my consultant was supportive to me. When he came in the morning, he didn't give her hypertonic saline, and she improved, actually, with normal saline and the electoral and the hormonal replacement only. So, and improved rapidly to above, not rapidly, but she improved gradually until she went. Yes, it was very slow correction of sodium, but what is the target? We don't want rapid correction of sodium. So usually be mindful of that you are allowed to give, but be very cautious. And these kind of answers, usually you have to tackle them in the exam very carefully. You have to show them that you are allowed to give it, but you should be very judicious about it, and should be a multidisciplinary team kind of discussion before giving the hypertonic saline in these cases. And as mentioned, you have either to follow the hospital policy, or especially if after midnight, but always have to ask for senior help, or ask for another specialty help like endocrinology or nephrology or whatsoever. So always show them that you are safe, and that you are always considering other potential complications from the therapy itself. So this is another patient. Could you interpret the
excuse me, sir. Just a question. Please, further clarification. So are you recommending the use of hypertonic saline in this patient?
No, I don't. No, I don't. I don't.
Okay.
No, I don't. That's what because obviously when you see the patient in the A&E and the diagnosis is not clear, the first thing, if you see this sodium, will come into your mind that maybe it's due to hyponatremia induced low GCS, and that's at this point you are justified to use hypertonic saline,
Hypertonic saline.
and no one can blame you. No one can blame you if you give the hypertonic saline. But once the diagnosis is there, and once the Rees-Mogg edema coma is already have been diagnosed, no, try to avoid using the hypertonic saline. Okay, it's not contraindicated, but try to avoid it. Just like the bicarb in the DKA. Got my point?
Yes.
Okay, thank you. So, and these kind of questions are very common, and you will find it even now in this session, that they want to know your point of view about certain thing, like steroids in septic shock, like short synectin test in septic shock. They might ask you this kind. What do you think about that? Okay, they want to know your point of view. Because if they ask you about giving if I ask you hypertonic saline, of course, yes, I'll give hypertonic saline, that they apologize, and they are not going to appreciate this very much. Okay, that they will think now that anyone who is going to give you a suggestion or any kind of hint, that you are going to follow this, and you are going to give them. They want to know that you know the pathophysiology of and the biochemistry of the disease itself, and know when not to give this kind of management, okay? And know the complications which might arise from giving this kind of treatment or therapy.
Okay,
yes.
Okay, I wanted to say, since this is a case of hypotonic hyponatremia, how about stating that you will restrict fluid in this patient?
Okay, why you want to restrict fluid?
Fluid restriction is one of the, I think, is the key
way to diagnose it.
modality.
Fluid restriction, either to diagnose, like in case of sciatica, or to treat as well, which happens in sciatica as well. But this kind of fluid restriction in intensive care is not practical. For how many years have you been practicing intensive care? I'm sure that you have been for more than 10 or 15 or at least 20 years practicing. How many times have you done fluid restriction in ICU?
Well,
for this kind of patients. For this kind of patients. I'm not saying about pulmonary edema or acute kidney or acute renal failure or acute kidney injury. I'm talking about this kind of patient. Patients with hyponatremia. How many times have you done fluid restriction for them in the intensive care? In this patient that sick?
Well, we usually may not give the full complement of IV fluid the person would ordinarily have needed. You may just give them like 60 to 80 mils per hour. You know,
that's not fluid restriction. That's not fluid restriction. That's not fluid restriction. That's not fluid restriction. If fluid restriction usually is much more than this. Okay, if you are going to apply the strict fluid restriction, which you do in sciatica for normal patient, normal conscious patient on the ward, that's very different. It's very strict fluid restriction. But just to reduce the fluid restriction, it would never, according to my experience, it will never reach the target you are asking for. Yes, it will never correct the sodium level you're asking for. Okay, especially in critical ill patients. Okay. So fluid restriction most of the time is not practical in ICU. We might try it a little bit, but it's not practical in ICU in those kind of patients. Okay, those patients she already comes with dehydration. She already comes with sepsis. How come you are going to apply fluid restriction for her? And she has got some sort of acute kidney injury. If you are going to apply fluid restriction, strict fluid restriction, you are going to damage her kidney. You got my point? So
yeah.
So at this point, it's difficult to say that we are going to apply fluid restriction, and that's what I'm going to discuss actually at the end of this, if we are going to reach the end of this session actually, because we are running out of time now. But you will find now that not all, some books write fluid restriction theoretical kind of information, but some, especially the intensive care books, you will find that fluid restriction usually is not practical in intensive care. Okay, especially in sciatica, for example. So this is another patient. Could you interpret the results, please? Now we are going to convert on some sort of short cases or CBS cases, okay? So that we can run quicker. Can you interpret the result?
So
what do you think this?
T3 is low, T4 and TSH are normal. So in critically ill patients, it could be CQ thyroid syndrome. I'm not sure what the background is, but
yes. So this is exactly this particular thyroid syndrome, and I want to give a fast hint about it that that you should know what's the pathophysiology of sickle thyroid syndrome, because they might ask about it as well. It might come as a vignette usually in a patient, in a critical ill patient with sepsis or with pneumonia, and then they're going to give you their thyroid function, and they're going to ask you whether you are going to give thyroid replacement therapy or not. So they're going to ask you what's a sickle thyroid, what happens for dysregulation of thyrotropic feedback control, and then in which the body is T3 is not active. Yes, there is a lot of inactive T3, which we call it reverse T3 or RT3, but it's not functioning properly, and it's not active T3, and because there is reduced conversion of T4 to T3. So in those to correct this kind of syndrome, you have to focus on management of the underlying critical illness, correct malnutrition, use IV triiodothyronine, which is active T3, support patients only if they have some form of cardiogenic shock, heart failure. Okay, only if there is some form of severe shock. At this point, you might consider using triiodothyronine, which is active T3, not levothyroxine, not active T4. Okay, this is some sort of diagram which helps you to know what's the pathophysiology of sickle thyroid syndrome, because it comes very frequent, because it's a very common syndrome in our daily practice actually. So, and you will find variation in the interpretation of the thyroid function. TSH might be high, might be normal, might be low. T4 might be high or normal. T3 might be low, but the issue here is to measure the RT3, which is the reverse T3 or the inactive T3. It will be high, and if you are going to calculate the T3 over the reverse T3, it will be a very low as well. Low. Okay, the ratio will be low. Okay, this is just a fast hint about, or rapid hint about the sickle thyroid syndrome, because it's very important to know about it. So this is another patient, 32-year-old man in the emergency department, Bay, and requiring critical care review. The patient has 7-week history of progressively worsening fatigue. What's your immediate action plan? Who's a volunteer here? Any volunteers? Dr. Muhammad, would you like to volunteer and answer this question?
Can I answer, sir?
Amran, okay, please. Amran, yes. So, could you interpret the results? Could you interpret the results as well first? What can you see here?
Sir, what I can see is basically the history is gradual and progressive. So presently, and also patient has presented with the low GCS, low blood pressure. So as we manage patients in emergency, we will take care of the airway first, and I'll make sure that his breathing is okay, oxygen saturation, carbon dioxide levels by doing ABG, they are okay. Then for circulation, initially we can give fluid, but again, if the patient requires more fluid, then we have to reassess fluid assessment. We have to do the fluid assessment also, and accordingly treat. Then look for disability, and also do E, that is exposure, and try to look for anything which is there.
Any differential diagnosis here?
Sir, one of the possible cause is hyponatremia. That is, I mean, that can be because of primary polydipsia or SIADH also. Like if the patient has some uh, uh, cause for it, like maybe undiagnosed malignancy or something like that. So SIADH can be there, primary polydipsia can be there, that can cause it. And Another differential is
if you want some sort of investigation now, what would you ask for?
Cortisol.
sir, in him, I would want to also see. Yeah, and there is one more adrenal crisis is also a possibility. So cortisol levels I would want to have here, and
Okay, great. So
yeah.
as you mentioned, ABCD approach, always ABCD approach, IV fluid resuscitation, cortisol level, ensure synactin, corticosteroid test, septic screen, IV corticosteroids. Then after you did your management, give IVs to emergency management could give steroids after you take the cortisol level or short synactin test or cousinotropin test. Okay, so now you have got this kind of investigation. The cortisol level. This is your investigation that you asked for. What's your diagnosis then?
Yeah, so this is basically adrenal crisis only, and that is not central cause. That is basically adrenal cause, and patient would require hydrocortisone supplementation. Along with that, we have to look for the cause. In India, tuberculosis is one of the very important cause in adrenal crisis, and maybe some other causes have to be investigated, like malignancy.
Great, Abraham. Great. So cause of adrenal insufficiency in ICU. So it's primary Addison disease, as you mentioned. So cause of adrenal insufficiency in ICU, as you mentioned, primary autoimmune, especially in the Western world, or malignancy, infection in the Eastern world, or in the Middle East or the Asia, it's usually TB or meningococcal, inflammatory, secondary insufficient ACTH production, secondary to pituitary pathology, or tertiary adrenal atrophy secondary to exogenous corticosteroid suppression, which we usually see it a lot in the ICU, and it can come as a vignette by itself in a long case. So always remember the cause of adrenal insufficiency in the ICU. This is not very exhaustive list actually, but just always consider all of them, because any of those can come in the ICU either as a CBS or as a vignette in a long case, especially in the tertiary one, adrenal atrophy secondary to exogenous corticosteroid suppression. So what is the rule of short synactin test and steroid in severe sepsis or septic shock? Of course, this question usually it might be given to you at the end of the station, just to see how the way of thinking, and give to examiners the way how knowledgeable you are about the guidelines and about the updates. Usually, the test is not recommended as a routine practice in severe septic shock, and this is since 2012. Survival sepsis campaign 2012, 13 years ago. But due to variation in the free cortisol fraction of the adrenal function cannot be accurately assessed in sepsis. So yes, all of us do short synactin test in our units, but actually it's not recommended, especially in the context of sepsis. So, but still we are giving steroids in case in vasopressors or refractive septic shock, according to the cervical sepsis campaign guidelines. So you don't have to do that test anymore, but in case of any patients who are on high dose vasopressors, especially in the context of septic shock, you have to give steroids, because even in the presence of normal short synactin test or cousinotropin test, it might be some sort of adrenal, some sort of subclinical adrenal insufficiency or adrenal malfunction, or increase in the steroid requirements. And this the studies, like adrenal study, has showed that it might reduce the dose of vasopressors given, but of course it's not improving mortality. So there is another patient. Any volunteer? Just I'm going to. It seems long, but actually this a 32-year-old man. He was a motorcyclist and had a traumatic head injury. He was taken to the theater or OR to have evacuation of extradural hemorrhage. He has several other cerebral contusions when keeping with moderate to severe traumatic brain injury. Over the past 24 hours, he has been assessed for extubation, and his GCS improved. his motor score was 6, which is high motor, it was good motor, and he was able to obey commands. But after this, he has deteriorated and now is only localizing to pain. That means there is a sudden drop in his GCS with significant agitation noticed during his last sedation hold. So when they were thinking about extubating him today, because he showed improvement, but now he is deteriorated again, and there is a drop in GCS, and he becomes very agitated. It is noticed that there was a mild hyponatremia since the start, which is now significantly increased and is now 118. So his sodium levels dropped over a few hours or 24 hours from 129 to 118. What's the potential differential diagnosis for hyponatremia in this case?
Cerebral salt twisting.
Cerebral salt twisting. Anything else?
Syndrome of inappropriate ADH secretion.
SIADH.
Okay. Yes, great. So cerebral salt twisting, syndrome of inappropriate ADH secretion, that's our top differential diagnosis, or maybe drug induced. Maybe he received diuretics at some point. Okay, so great. So what specific investigation would you order to differentiate hyponatremia between cerebral salt twisting and SIADA? This was your question, John.
Assessment of the clinical assessment of the fluid status of the patient.
Okay, like what?
Yeah. Is a serum osmolality?
Okay.
Serum and urine osmolality, and of course, serum sodium is already given an urine sodium concentration.
Okay.
We would like to do a POCUS assessment and try to look for the signs of hypovolemia versus euvolemia. Like cerebral salt twisting will have hypovolemic status, IVC we can see, and also we can see the ventricles and overall status, fluid status of the patient.
Very good answer, Amran. Karthik, do you want to add anything?
I don't think I have much to add in terms of, because there's no difference in terms of serum osmolality, and urine spot sodium is going to be more than 20 in both. It's very difficult to differentiate. Obviously, the treatment is completely different. In SADH, it's fluid restriction, and in cerebral salt twisting, giving more saline. So obviously, it has to be clinical decision in terms of hemodynamics and POCUS, as it was told already. So it's going to be a tough one. Sorry.
Very good answer. All of these are very good answers and very reasonable answers, actually. So, but in addition to the normal basic thing, serum and urine sodium, serum and urine osmolarity. So just don't forget about the urine sodium and urine osmolarity in this context. But all of your answers were great answers, actually. And this is going to give very good impression to the examiners, because they like those who apply their daily practice on their answers. Because the issue here is to differentiate between the patient who is euvolemic or normovolemic and hypovolemic, because this is the whole message of this, or the whole message from this question. The one will be hypovolemic, but not severely hypovolemic, not dehydrated, and one will be normal or euvolemic. So how are we going to differentiate? Like mentioned, clinical ultrasound, and of course serum and urine sodium, serum and urine osmolarity, which was mentioned as well. So serum and urine osmolarity are requested, and the following results are obtained. What additional clinical information would you require to supplement your biochemical data? I think you mentioned them already: the ultrasound, volume states of the patient, and urine output, whether the patient oliguric, anuric, and whether and we might use the POCUS or ultrasound as well. Okay. Any questions so far? So the patient seems to be hyponatremic. Serum osmolarity is hypotonic. Urine sodium is a little bit high, and urine osmolarity is high as well. So what's the diagnosis now? Most properly,
it's SIAD.
SIAD. Okay, that's right. That's right. So this is more clinical data from the same patient. Fluid balance is positive, 2.2. The patient doesn't appear dehydrated, and so the most clinical diagnosis is SIADA, as mentioned by John. Of course, this is some sort of table to give you the difference between SIADA and cerebral salt twisting. Here, there is a patient is fluidly depleted here it's normal, or maybe hypervolemic urine output, he will be oliguric in SADA, or normal urine output, it will be polyuric in cerebral salt wasting. Urinary sodium will be elevated in SADA and in both cerebral salt wasting as well. Hyperuricemia, which is the first time to note this as well, that hyperuricemia will be low in both. Fractional excretion of phosphate, which I have never used before, it will be low in SIADA and elevated cerebral salt wasting. Of course, this comes out of theoretical kind of information. And of course, serum urate level will be low in both, and fractional excretion of urate will be normal in SIADA and high in cerebral salt wasting. This kind of theoretical information, you are not expected to know that in the exam, and you don't expect to answer them, but who knows? They might bring it as some sort of, as a part of the, in the table content, because they give you a vignette or question and then a very long table, which you find sometimes confusing. So they might bring this kind of information just to give you a hint about it, but it will not be a vital information to diagnose the case. And this is some sort of algorithm. There are a lot of algorithms to diagnose hyponatremia. This is the easiest one I have seen, 3-step process, and it's all about the sodium, the hypovolemia, and the osmolarity. So it's almost about sodium concentration, the urine sodium, plasma osmolarity, and urine osmolarity, and about the volume status, which is the most important question to answer here, the volume status of the patient, especially in the context of the exam. In the exam, you'll be a little bit stressed, not a little bit, will be a lot stressed. So you would not think about fractional excretion of sodium, urea, and phosphate, of course. So it's about always about the volume status. This will be the biggest hint for you, and about the osmolarity. And those are the key things you are looking for. So what factors will influence your management plan for hyponatremia? Anyone would like to answer?
Yeah, just like you said, is the volume status of the patient,
Okay.
you know, and
the rate of fall of sodium,
plasma osmolality.
Okay. Yes, exactly. So the rate of fall of sodium, the degree of hyponatremia, and the patient has attributed symptomatology to hyponatremia like agitation, confusion, fluctuations, conscious seizures, or coma. That's what will influence us, how we are going to intervene, and what method of intervention this would be. Okay? What management should be instituted for those particular patient and why? For this particular patient, the one who had head trauma or traumatic brain injury. Any volunteer?
Okay, in this patient, I think fluid restriction will be appropriate.
Restriction. Okay. Yeah. What else?
And Vaptans can be tried.
Give
ICP monitoring.
Vasopressin. Okay.
Tolvaptan. Vaptans to increase.
ICP monitoring.
ICP monitoring.
Fluid restriction, diuretics.
Most of these patients already have got ICP monitor. So most in the Western world, Dr. Muhammad, most of them already have got ICP monitor. So you might mention it to see if the therapy of there is to monitor your management, because to avoid any kind of occurrence of brain edema. But usually most of those patients already have got ICP, some sort of ICP monitoring. He went to the theater, so most probably he would come in any neuro ICU. Or trauma ICU in the Western world, they would come from the theater with, or from the OR with ICP monitor already. Yes. Priyanka, you were saying something, and before I interrupted you.
No,
Priyanka,
same only, I just.
Sorry?
Nothing more, sir. I was saying fluid restriction, diuretics, and saline should be given for the SIADH. Tolvaptans are usually given in chronic management. In acutely, we should be giving this one.
Okay. So the patient has a rapid fall in sodium and is now symptomatic as well. Although fluid restriction is the mainstay of management, allowing steady rise in serum sodium, in this case 1 to 1.8 to 3% hypertonic saline should be given as the patient is compromised. Because as I mentioned before, as discussed with John, fluid restriction is not practical in those kind of patients. is in ICU in general, especially in traumatic brain injury patient in particular. You cannot apply this kind of fluid restriction. You cannot induce dehydration, you cannot induce another acute kidney injury, okay? So, and fluid restriction might cause uncontrollable rise in the sodium here. You want to control the rise of the sodium as well. And the sequelae of fluid restriction might be more severe than the sequelae of not restricting flows too much. So once sodium level reach 120, 125, the hypertonic saline should be stopped and fluid restriction continued, okay? But in order to be fluid, the patient should be stable. They should be stable to apply this kind of fluid restriction, okay? So this patient is not stable at the moment, so we can give the hypertonic saline. And sometimes it's not to be said in the exam, but sometimes we give also vasopressin, as you mentioned, especially in the case of severe polyuria, but not to SIADA. Once SIADA has been diagnosed, usually I'm not going to give vasopressin. But for example, sometimes you give vasopressin, although we are very sure that this patient has got cerebral salt wasting syndrome, which is not part of the guidelines or part of the usual practice, but sometimes you have to give it, especially in the context of severe polyuria. Okay, so all your answers were not wrong, but we are looking for the answer they want us to answer in the exam. And usually we have to give some sort of theoretical answer, but to show them as well that we have some sort of clinical orientation of what we are doing. Yes, we are going to fluid restriction, but in this patient where there is agitation, with severe manifested hyponatremia, we are going to give sodium as well. And then we might apply fluid restriction if the patient is stable enough, which you will never find as in any neuro ICU. I've never seen them applying fluid restriction actually as it should be. So what is the risk of rapidly correcting a hyponatremia? This is an easy question. We said it. What's the risk of rapidly correcting a hyponatremia?
Central pontine
myelinolysis, of course.
Osmotic demyelination.
Yes, exactly. So other pharmacological agents that described and can help in SIADA as well, I think you mentioned most of them, the meclocycline, ADH receptor antagonist, okay, like Vactan, okay. Those are all the agents that we are using for the SIADA. So, and actually those we are using every day in our daily practice. I worked in neuro ICUs before. I've never seen fluid restriction being applied actually in any patient who is being diagnosed with SIADA, okay? So, what do you think about this?
Diabetes insipidus.
Diabetes insipidus. Why?
Serum sodium is high, osmolality is high, urine sodium is 26, urine osmolality is low.
Okay. This is the same patient after 10 days. Yes, this is the same patient after 10 days. He developed some sort of
central DIC.
Yes, 3 days. Okay, yes. Central diabetes insipidus. Okay. The likely cause, as you mentioned, the change of the urine output and after becomes biliuric, and this kind of picture is diabetes insipidus. Okay, this is the same patient. So, what's the management of diabetes insipidus?
Desmopressin nasal spray.
Okay, desmopressin. And of course, ABCD. Bianca, don't forget. Okay, not because you mentioned before, I don't have to mention it again. Okay, sometimes you have to mention ABCD 4 or 5 times in the same exam. Okay, because there are 4 cases. So, treat hyponatremia, of course, ABCDE. As you mentioned, treat hyponatremia, address the deficit in total water by water or via the NGT or via the NGT usually, because usually we don't prefer to give hypotonic IV fluids to those kind of patients to avoid brain edema. Supplement ADDH, DDFB 1 to 4 mics per kg per day, 1 to 4 mics per day, not per kg, per day, sorry. And treat any underlying cause. Prognosis of ADH. What's the prognosis of ADH? Central ADH. Diabetes insipidus. Sorry, diabetes insipidus. What's the prognosis? Okay, it's high mortality rate, 57, sorry, this is not ADH, diabetes insipidus, sorry. I'm very sorry for that, but associated with higher mortality rate, 57 to 69%, and 86 to 90 if it's very early, less than 3 days after injury. Of course, in any patient with brain death, usually most of the patients with brain death have got diabetes insipidus. Hyponatremia correlates with higher mortality as well. Hypernatremia correlates with higher mortality, especially if sodium above 160. Okay. Another case-based scenario. Sorry.
Okay, just give me
I gave you the answer already. Any volunteer who didn't see the answer? Anyone who didn't see the answer would like to answer this question? Priyanka would like to answer this question?
Yes, sir. So this is a 53 years old obese gentleman, past medical history, ischemic heart disease and hypertension, emergency department, confusion and combative. A febrile heart rate is 113 beats per minute, blood pressure 108/74, respiratory rate is 28 breaths per minute, saturation 96% on room air. What is your diagnosis and what therapy will you initiate? So creatinine is high, sodium is high, potassium normal. Blood sugar is 36 millimoles. This is too high. Serum osmolality very high. Urine osmolality. And sodium. Calcium very high. Magnesium is low. So patient is in confusion and is combative. With a
Yes.
high blood sugar level. So this looks like osmolar hyperglycemic state. The
Great.
patient is in
Great. Great. That's good. That's why hyperosmolar hypoketotic state, as we have discussed it before. So it's usually the same management like the DK almost, but of course it's patient are usually more dehydrated and more hemodynamically unstable. Okay. And we are going to apply the same. And of course, don't forget the anticoagulation prophylaxis because of the thromboembolic events are more severe. And here patients are more liable for both brain edema and central pontine myelinolysis. So, and remember this, just I brought it again because you might have a case in the CBS and you might find it again in the next day on the clinical case scenario. Okay, so don't just exclude that because the case was brought in the case-based scenarios that cannot come again in clinical scenarios. Okay, and sometimes you can find the same vignette, for example, adrenal suppression in the first vignette where adrenaline crisis and adrenal suppression due to steroid withdrawal in another vignette in another long case. Okay, just always answer with the first thing comes to your mind because it's usually the truth. If you are well prepared and well confident and you are really have got some sort of experience in the intensive care, the first thing will come to your mind, say it, and don't shy of saying it. Don't shy of mentioning what's in your mind. Okay. Because there are no negative marks. First, there are no negative marks in this exam. As long as you are safe, you prove that you are safe and you are not, and the safe physician, they are going to appreciate anything you say. Okay. And even if you don't appreciate, they're not going to give any negative marks because of it. Okay. So the message here, the questions can repeat in the second day of the exam and can repeat even in the same exam. You can see it in short question and you can see it in another vignette in another long case. Okay, the rationale, of course, known why we diagnosed and why the rationale of the management. This is some sort of unfortunately important equation that we all need to know about the calculated osmolarity, osmolar gap, anion gap, corrected sodium, and corrected calcium. Okay, just memorize them, please. Okay, the next case, John, would you like to answer this question? John?
Okay. Yeah.
Yes. The active participants, yes.
34-year-old lady who was admitted with fever, altered behavior, and a rapid decrease in level of consciousness necessitating invasive airway support has been noted to have a urine output consistently greater than 150 mL per hour. A lumbar puncture is performed and the results, along with her biochemistry, is displayed below. What is her diagnosis? Okay.
I just wrote the urea and creatinine in numbers in milligram per deciliter because some of you are not used to millimoles. So don't be confused because of those urea and creatinine, just interpretation of those units, okay? So what's your interpretation? Regarding the kidneys, for example, what you can find here? Renal
Okay.
function.
Okay.
What are they?
There's obviously pre-renal azotemia, significant. The urea level is markedly elevated compared to the creatinine, so it's
Exactly,
most likely
exactly.
pre-renal
Pre-renal
azotemia.
azotemia.
But there's acute
This
kidney injury.
pre-renal acute kidney injury. Yes. Just be aware of those kind of. I think that most of them would accept this kind of this term or this diagnosis, but just they don't like it anymore this time. The azothemias and they just mention the acute kidney injury, and because
Okay.
you know some of the examiners are much younger than you, and maybe they haven't read this kind of terms any recent published books. Okay, so just because now they are hiring very young examiners. Okay, so because they are short of examiners, so and usually not all of them are appreciating that you're using all terms. But anyway, that you're right. It's pre-renal azotemia or pre-renal acute kidney injury. So what about the lumbar puncture? What do you think it is?
Okay, there is obviously bacterial meningitis is very likely. Polymorph levels are very high.
Okay.
The glucose level is also okay. It's normal. Protein is elevated. Okay.
Elevated. So it's bacterial meningitis. So what's your diagnosis of this patient? Deranged lab results or deranged biochemistry?
Okay.
What do you think he has at the moment?
Okay, he has a central diabetes insipidus secondary to bacterial meningitis.
Central diabetes insipidus. Okay. Hyperosmolar hypernatremia. Rationale, of course, hyperosmolar hypernatremia. Most probably in the context of intracranial pathology, then it might be cranial diabetes insipidus, and of course, an elevated serum uric acid also supports cranial over nephrogenic diabetes insipidus. Actually, I didn't know this as well. That this is a new information for me when I'm preparing this. That elevated serum uric acid gives you more idea that it's a cranial pathology other than nephrogenic pathology, and of course, pre-renal urea to creatinine ratio and increased serum albumin all suggest intravascular volume deficient and consistent with the diabetes insipidus. Great, John. So I think it's the last question. Who's going to be the last volunteer? Who's the brave one?
Can I answer?
Yes, please. Amran, please. Yes, please. Answer.
I'm just reading the question.
Okay. Can you read it loudly, please, if you don't mind?
Yeah, a 59-year-old lady on the ward has recently been treated for painful active rheumatoid arthritis. While awaiting completion for her discharge planning, an emergency call is put out for a witness collapse that occurred when she got up to use the bathroom. The first IV volume bolus has not improved her blood pressure. What therapy would you consider next? And these are her results. Creatine 1.03, serum osmolarity 273, that is normal. Urine sodium is slightly elevated, 47, and sodium levels are on the lower side, 127, potassium 5.9. Calcium is high, no, not high, it's not ionized calcium, it's okay, it's normal. So during discharge planning she collapsed, and initial fluid bolus has not improved the blood pressure. So we would like to start noradrenaline therapy for her, and also reassess the fluid status, and may give additional fluid also.
So what's your diagnosis now? Sorry?
And
What's your diagnosis?
I'm not able to understand why she must have collapsed. Maybe sepsis because of her rheumatoid arthritis treatment. Some immunosuppression might have been given, and she must have developed some hospital acquired infection leading to hypotension.
What else?
That is one thing I can think of. And yeah.
Okay. Other than the fluids and the,
okay,
yes.
Let me. It's likely she has adrenal insufficiency. She may have been using steroids, drug induced. Steroids may have been part of her treatment for the arthritis. So it may have.
So what are you going to do? What are you going to do for her? This is one of the differential diagnosis. What's you're going to do for her now?
Okay, I would like to give a bolus of in this case, this is like to is fluid cortisone also.
Yes,
yeah.
Great. Okay, so it's you're right, John. The answer, of course, we are going to give her hydrocortisone or 4 milligram dexamethasone IV. The hydrocortisone is more rapid in action, and it has both mineralocorticoid and glucocorticoid effects. But dexamethasone, the benefit of dexamethasone that it would not prevent us from doing short synactin test, which is the only rationale here. That's not going to prevent us from doing the short synactin test. But any of those answers are okay. And of course, starting her on her prednisolone again, and rule out any kind of triggering factor like sepsis or anything. But we read, obviously, that the reason here is for this adrenal crisis secondary to acute steroid withdrawal. So, and of course, the indicators here are the postural hypotension and the blood pressure not responding to fluids, and hypoosmolar hyponatremia with elevated potassium, urine sodium more than 20, low blood glucose, or at least on the lower side, and anion gap, high anion gap, normal anion gap metabolic acidosis. All of these are giving us some sort of a hint that this patient most probably developed some sort of adrenal crisis secondary to acute with steroid withdrawal. So, but anyway, as I mentioned, it's you are not only expected to answer the right answer from the first time. As long as you're giving them proper differential diagnosis and give them a proper management plan. So if you just mentioned the steroids and good differential diagnosis, even if you didn't mention the first diagnosis first, it's okay. There are no negative marks as long as you're showing them that you are on the right pathway, that at the end of your pathway, you are either going to reach the right diagnosis or are going to save the life of this patient. So these are my references, the books that I use. Some of these I used for this kind of to prepare this lecture. And you have got my phone number, you have got my email. Anyone would like to ask me anything or any kind of want me to share anything with them, I'm happy to receive your messages at any time. I know that the exam now is approaching and the stress is increasing, but I wish you all the good luck. And my only advice, practice. Don't spend too much time reading theoretical kind of knowledge. Read OSCE books as much as you can, even if it's not on the EDIC style, but it's not going to be a waste. You are going to learn something new from any kind of examples or OSCE questions you are going to encounter. And thank you so much for tolerating me. And thank you so much for your participation, especially the 4 or 5 active participants here. I really appreciate your active participation. And I hope that every time I'm going to have more active participants, because this is the only way you are going to get benefit out of those kind of sessions. Without participation and being only a listener, you're not going to, it's not going to be a very useful session. This session is about simulation. It's about letting you live the actual sensation of the exam, the actual atmosphere which you are going to see or encounter on the exam day. So don't be shy, don't be stressful, okay? To make mistakes here or to forget something here is better than to make mistakes or forget something on the exam day. Participation, practice are the only advice I can give you. And thank you so much. And I'm sorry again for running out of time, but I just want you to see as much cases as we can, and don't want this kind of session to be boring for you. Thank you so much.
Thank you very much. God bless you.
And please don't forget the feedback. Don't forget the feedback to see if this kind of designing the lecture was good enough or not for you. Please, I'm waiting for your feedback. Thank you so much. Thank you so much. Okay.
Thank you, sir.
Thank you.
Thank you.
Good luck.
Thank you, sir.